with the past, just briefly to kind of bring us up to date, what a lot of you in the room already know about CMV, and then I'll talk a little bit about what's happening now and kind of where we're headed in the future. And I'm hoping that by the end of the talk that I can convince some of you that we probably should be doing CMV screening, either by a targeted approach or there's a real push now for universal CMV screening. So we're going to talk. So basically about, so one thing to say is that UAB is a leading institution studying congenital CMV infection. I'm one of a group that that didn't start with me. I've just had the privilege to work with some outstanding individuals. So what happened was in the 1960s, they started noticing that they'd first noticed in autopsies of infants who had died these inclusion disease that they sort of started to see, and they started to describe it in living newborns. And in fact, Dr. Weller, among others, had described this in the early 1960s. And Dr. Charlie Alford, the late Dr. Charlie Alford, who I guess is the grandfather of congenital CMV infection in Alabama, returned to UAB after working with this Nobel Prize winner and formed an infectious disease group that has been studying CMV since the 1960s. So you may have heard some of the names: Dr. Charlie Alford, Dr. Sergio Stagno, Dr. Robert Pass, Dr. Rich Whitley, Suresh Bopanna, Bill Britt, Shannon Ross is with us now, and myself, among others that have come and gone from our institution. So we're there. So when I'm talking about congenital CMV infection, I'm talking about infection that's transmitted from mother to fetus anytime during gestation, and there may or may not be any cause, any apparent damage to the fetus. So what happens is, for a symptomatic baby, what you might see is disseminated disease. So these are all outcomes that are going to kind of resolve. You may have a generalized petechial rash on it. You'll see an infant with that, or they'll have jaundice, or they may have an enlarged spleen or liver. They have a thrombocytopenia, low platelet count, or even more severe, they'll have seizures or have intracranial calcifications. They'll be microcephalic. They'll have some other neurologic deficits, and they can even have some retinitis. So this should sound, if you've been reading the literature lately, a little bit like Zika. So this is only about 10% of the babies that have CMV, and these are the ones that are going to be identified most of the time in the NICU. But the other 90% have no clinical manifestations. So they're just sort of under you've seen the tip of the iceberg and then underneath. And unless you're screening for these babies, you're not going to even know they're around. And so why is that important? My slides are a little bit off, but anyways, the sensorineural hearing loss occurs in about 19%. These are sort of some of the sequelae. They can have cognitive development issues. They can have retinitis, cerebral palsy. They can have other neurologic problems, seizures. And some of the children who CMV can also cause death or stillbirth, but there's also, many of these children can be wheelchair bound and also have hearing loss and have other cognitive effects. So symptomatic babies are more likely to have permanent sequelae than the asymptomatic. So the most common thing that happens, sequelae that occurs, is going to be hearing loss. So about 40 to 50%, it's estimated, of the symptomatic babies will have hearing loss. And I'll talk a little bit further about hearing loss in a bit, but either at birth or in the early years of childhood. And the same with the asymptomatics, a little bit lower rate. So in the past, how we diagnosed congenital CMV infection was with urine, where they would bag the baby, grow the virus, isolate the virus in culture. It would take 5 to 6 or 7 weeks. So you can see that that was what we were doing up until the late 80s and early into the early 90s. And then we started to do more identification of the virus in the saliva in the early 1990s. And switch, because it was much easier to swab a cheek of a baby than to put a bag on a baby and collect urine for various reasons. So this still, but these were both, but this was very labor intensive, somewhat costly, and so this was the standard, the gold standard. And during the same time in the past, we spent a lot of time, I'm using the term we use now as non-primary, but we talked about primary infections. That seemed to be what everyone was focused on and what we thought was most important. So this is what we mean by that is a seronegative woman who somehow or another acquires CMV the first time during pregnancy, and then they are at greater risk of transferring to the infant, and it's around 30%. So. And then the seropositive women at this time, we thought they were having some kind of reactivation because CMV is kind of a chronic infection. And then, whether CMV could be the result of a reinfection, they weren't really certain. But so if you had a primary infection during pregnancy, you were 30% chance to give to the fetus, where somewhere we think it's around 1% if you already were positive before pregnancy. So, and even we showed that they had that preconceptional immunity was somewhat protective, but it was incomplete. And so those that had primary infections, this is some work that I did as a fellow, published in the New England Journal of Medicine, we showed that they had a higher rate of sensory neural hearing loss, and they also had, any sequelae, they were more likely to have it. So this has been the thought, this has been the process we've had. I'm going to skip that because of time. So you're thinking, well, okay, so we know how we can diagnose the virus. We know that we have it. So what is it? And what's the epidemiology of this virus? So it's a herpes virus. It's very common. It's transmitted through direct and indirect person-to-person contact, through infected secretions, saliva, urine, breast milk, cervical, vaginal secretions, etc. It's not very contagious, so it's not like the flu or some of the other viruses you may be familiar with. It requires close and intimate contact with infected secretions, and it's usually going to be asymptomatic in the immunocompetent host. So in other words, if you were to go today, you could guess whether you were CMV positive or negative, but you probably wouldn't have known when you acquired the virus. And the way they would know you were positive or had past exposure would be a serology test. It would say you have IgG to CMV, anti-IgG. But so you look here, this is done in Haines data from the CDC, and I've taken females and the three groups. And so the red group is the non-Hispanic whites, and then we have the green group is non-Hispanic blacks, and then we have Mexican Americans in the yellow. And what you see is around 6 to 11 years of age, the white, non-Hispanic whites are around 30% seropositive, and the other Mexican Americans and the non-Hispanic blacks are slightly higher, but less than 50, maybe about 55%. And then as you see, as they get older, they continue to, all of us, this tends to happen. So if you were to test like 80-year-olds, we'd find that most of them were in the United States were seropositive for CMV. They've been exposed sometime in their life. And it's not very well showing up. But the circle is just sort of, you see it's climbing during childbearing age. So it's the opportunity for women to have exposures. So CMV seroprevalence rates pretty much in the Western world, Canada, Australia, England, Western Europe, range from 30 to 60% in women of childbearing age, resulting in women who are susceptible for acquiring CMV for the first time during their pregnancies. However, what's interesting in Asia, Africa, and parts of Central and South America, most of the women come into childbearing age with greater than 70% seropositivity. So most of them are already had exposure to CMV, possibly through breastfeeding or early childhood things. So they're almost at 100%. Like in India, all the testing we've done there, the women are 100% seropositive, but they still have babies with congenital CMV infection. Same we've seen in people who've studied Africa, and also we see that in Brazil. And so the yellow bars are just showing that congenital infection rate goes up the higher the maternal seroprevalence rate is on the side there. And so it's kind of counterintuitive, isn't it? I mean, you would think that if you had more susceptible seronegative women, you should have more CMV, but that's not the case. And so we'll come back to that. I don't have the answer. Maybe someone here can help me figure it out. But anyways, so how do women or potential mothers to be acquire the virus and pass the virus on to their infant? One source of virus is young children. So either in the household or a friend's or a family's children. And so CMV is very prevalent in daycares and other places where young children gather and play. Studies in daycare centers have shown that young children shed the virus in the saliva and urine, creating exposure opportunities for the virus to be transmitted to other children, to their parents, and to the daycare or nursery workers, especially toddlers who are drooling, have lots of saliva, and who share their lovely toys with us. You know how they like to put it in their mouth and you put it in your mouth, right? So the children may acquire the virus and in fact have previously seen be negative mother or caregiver. So pretty much if you could sanitize the toys and surfaces to prevent the spread of flu, you're also going to clean the surfaces of CMV. However, CMV is fairly ubiquitous, so it's unlikely that any daycare or any place where children are interacting with saliva-laden toys that you're going to completely be free of the virus. And that doesn't have to be just daycares, that can be church nurseries, that can be anywhere where children play together at your house or in the community. So another source of CMV infection is sexual activity. So CMV can be transmitted through the semen or vaginal secretions. Though it's not considered a sexually transmitted disease, it is sexually transmittable. So a study that we did I did a couple of years back. Well, it's been a long time now. I'd like to think it's just a couple of years back, but anyways. We were looking at, so we had women who had infants who had congenital CMV infection, and then we had controls. They were women whose babies tested negative for CMV. So we wanted to see what was different. I did the study thinking we were going to see in Birmingham, Alabama, that there was a lot of sexually transmitted CMV. Of course, I was wrong, because what we found is that about the women who took care of young children in the 12 months before their delivery were almost 3 times more likely to have a baby with congenital CMV infection than a mom who didn't take care of children. And then the same, and we saw some, but when you combine together, if they'd had recent onset of sexual activity as well as taking care of young children, it was 7 times more likely than those that didn't have those 2 factors. So taking care of young children, and what we meant by that is feeding them, changing diapers, caring for them, in some kind of routine way. It wasn't just sort of passing them and patting them on the back or something, but some involvement with them. So, and the other thing I always wanted to say, and this is an example of one of my slides that this morning at 4:30 I went, why? Young maternal age is another factor. It's interesting that women that are younger are more likely to have a baby with congenital CMV infection. And then the other thing is, and here's an example of a little bit more recent data that we have where, oops, let me go back. You can see that less than 20-year-olds have twice the rate of congenital CMV infection in their babies than those that are 20 to 29 years old and 30 years old. So good news about us decreasing the teen pregnancy rate, and that itself is wonderful, is that you also decrease congenital CMV infection too, as an aside. The other thing that there is a difference by race and ethnicity. We see black women, black infants are you're twice as likely to have a baby with congenital CMV infection if you're black than if compared to white women who are non-Hispanic. And we thought the same thing would hold up, I'm going to skip the multiracial right now, with the with the Hispanic women, because if you remember that graph I showed you a little while ago, the Hispanics were the highest, weren't they? So what I told you too, and we don't really know what's going on here, why they don't, but they're very similar to the white non-Hispanics, and we don't know what that means. And we're not sure, we've adjusted here for possible any other effects such as maternal age and insurance status and some things. So this paper is in process to be published. But so in this graph, it's just showing you that if we break out the yellow bars, the non-Hispanic black infants that born to less than 20-year-olds, they're the ones at greatest risk, almost 20 per 1,000 versus some of the other groups. So it just shows that, so if you're working in a hospital that has a population that is a little bit younger delivery age and has African Americans in there, you could consider, you're going to see a higher rate of congenital CMV infection if you're screening for them for that. So the present, so I kind of jumped into the present a little bit. So people right now in the CMV field are very interested in this non-primary maternal infection. So when I first started in CMV many years ago, I was told, I actually started late 80s and started my fellowship in 1990. I was told that, you know, you're not going to have a career in CMV in just a couple of years because we're going to have a vaccine. Well, they're still working on that vaccine. And, you know, I'm almost at the end of my career. But part of the reason is that thing that I showed you, that we have women who are exposed to CMV in the past but still have a baby with congenital CMV infection. So if natural immunity is not perfect, then how do we expect a vaccine to be even better, right? So, I have to say, there's several companies now working on vaccines. They've been trying different approaches to see. But what this graph shows is that as the population gets closer to 100% CMV seropositive, almost all of those infections are non-primary infections. So there's studies, different groups in Italy, here in the US, and in Brazil. We're trying to understand, what is it? Is there something about the immune process? I mean, you know, all of the women transmit, so there must be something that's changing, and we're trying to sort that out. So one other thing we've done at UAB is we were fortunate enough to get a large funded grant from 2005 to 2015. UAB was the lead institution to look at CMV and hearing loss, but also to look at some of the diagnostic testing for CMV. Could we do it with dried blood spots, for example? Because that would obviously be perfect, to be able to test for CMV and dried blood spots. Or were there other approaches we needed to take? And so we were at we were in Alabama, Mississippi, New Jersey, North Carolina, Ohio, Pennsylvania, and Texas. So we had about 100,000 infants that were screened for congenital CMV infection. And what we found, we did the dried blood spot PCR, and it just wasn't sensitive enough. They did 1' or 2'. We don't have to, you can reference the paper if you're interested in the details. But it was less than 40% sensitive, so obviously not a good screening test for CMV, which was very disappointing because now we're introducing, if we want to propose screening in the future, we're introducing another substrate, you know. So we took the same primers and looked, and my red boxes I noticed this morning were down further than they should be. And we found, we have liquid and dried saliva. So we found that it was about 100%, 99, 97% to 100% sensitive, high specificity. So let me go back real quick, just say one thing about the DBS. So you'll have people, though, contact the state, or some states store the DBSs, and I think, and different things, or an ENT will call because they have a child with hearing loss and they don't know and they want to test the baby for CMV. You can do a test on the dried blood spot for CMV. If it's negative, it doesn't tell you anything. But if it's positive, you can be fairly certain that it is congenital CMV infection. So there are states that use this, or ENTs who know how to access within their states, such as Utah, I think in Washington State, I know that they do it, and I'm sure there's others. So I just wanted to comment on that. But what we did is we had the traditional thing. We put the swab in the baby's cheek, and then we put it in transport media, put it in the refrigerator, take it to the lab, and test it. That's what we call by liquid. It worked. It was great. I think we had 100% sensitivity and 99.9% specificity. We said, well, you know, there's still a step in there, right? We got to get media made, all this. Let's try it by just putting the swab in the mouth, putting it in a sleeve, leave it at room temperature, and then when they drop it off to the lab, they can put it in the refrigerator. And that's what they did. And even that was highly sensitive. So that's what we actually use when we do studies at UAB, and we recommend for other people to do. So and it's fairly rapid. It's a relatively inexpensive diagnostic test. I mean, it doesn't cost much to do it. It doesn't necessarily mean that a lab that's doing it isn't going to charge you a lot of money. That's a different story. And just to show you, we always thought, you know, there was this view that urine had a lot of virus, CMV virus in it, had high quantities. And when we look, actually saliva has just as much, if not more. So that's why we argue that saliva is much easier to collect, and it's good. So this is on screening, and then we had to follow up. So what you would do if you were trying to identify a child with CMV infection, you would screen them. If they tested positive, you didn't do a diagnostic confirmation test, you could use do PCR, but you might then want to collect a urine and a saliva just to check. Because some people say, well, what about breast milk? We found a very, very low, like 0.08% false positive rate, so that's pretty good. But there's always that concern, so if you want to rule that out, you can do urine. So it's not saying that urine you shouldn't do, but it's just for a screening test, we recommend saliva. So what we also found in this study was that 4.5 per 1,000 live births was the overall prevalence for congenital semen infection. So that's basically, to put it in another term, 1 in 200 live births. I think I brought a couple of brochures, and we've been still saying 1 in 150. But I think it really is probably, we're a little bit, I think, more precise in this measure. And then, like I mentioned earlier, you see that overall, it's 4.5 per 1,000, but in black non-Hispanics, it's 9.5 per 1,000, and in white Hispanics, it's 3, and whites non-Hispanics is 2.7. So it's very much breaks down, it has some disparities there. So also, we looked at sensorineural hearing loss at birth, and it was defined as the present with the first full diagnostic audiology evaluation. So this is not, as we heard earlier, a refer on the newborn hearing screen, because they may or may not have hearing loss, but we did a full diagnostic ABR and found that they had sensorineural hearing loss. So in the children in this study, 7.9% had sensorineural hearing loss at birth. And it broke out as we expected among the asymptomatics and symptomatics, where 4.7 of the asymptomatics, those that didn't have any other appearance of infection, had hearing loss, and 38% of the symptomatics. And so the asymptomatics are more likely to have unilateral loss, where the symptomatics are more likely to have bilateral loss. And one thing you may not know about CMV is that it has progressive loss. In other words, children can have further worsening of their hearing. And so 67, over 50% of both symptomatic and asymptomatics have further deterioration or the hearing loss. So it's very important for them not only to be identified with hearing loss, but to follow them, because the hearing loss can become worse over time. They also have kind of a funny thing called fluctuating hearing loss. And when I was a young fellow, Dr. Art Dolly, who was the audiologist, we kept seeing this fluctuating, and I kept quizzing him. Like, I didn't trust him. He finally said, Karen, it can happen. So he educated me about audiology and testing, etc. So what's happened is there's an antiviral that you can, and I'll come to what the standard is for treating, but there are pediatricians who treat infants when they find out they have congenital CV infection, and there's also been some trials, and they've shown that in the trial, which I'll come to in a minute, that you can stabilize the hearing loss. So we happen to have in the CHIME study some children, by our definition, were asymptomatic or symptomatic that had been treated at birth, but you can see that out of 4, that only 1 of them remained stable at 4 years of age. So the antivirals aren't perfect, and they're not as long-lasting as we hoped. We don't know yet, so there's further study to do. And that's just all that this shows. And then the other thing that's unique to CMV is that you can have a child who's born at birth, who's perfectly fine. If you didn't screen them and they're asymptomatic, you would know, and you'll have a child at 3 or 4 years of age present with unilateral hearing loss, and nobody knows why. And that could be congenital CV infection. In fact, we get calls from parents who said, I just took my child, and they're 3.5 years old, and they have a unilateral moderate hearing loss. Can that be CMV? And we have to say, well, if you don't test for CMV in the first 2 to 3 weeks of life, you can't know for certain. So they say, well, can I get the dried blood spot? And we say, well, you can, but only if it's positive is it going to tell you anything. So it's frustrating. So we do have a lot of late onset. You can have the asymptomatics tend to fluctuate. That means goes up and down. Like they'll be at mild, they'll go to moderate, they'll go back up to mild, they'll drop to severe. And then eventually, many of them will drop to severe and profound and stay there on their loss. So that's what we see here, is that quite a bit of it goes to severe, profound loss. So the thing I would say about CMV auditory hearers, the hearing may be normal, or if they have hearing loss, it may be present at birth, or it may be delayed in onset to the early years of life or after several years of life. And in fact, there's a recent study out of Texas that the CDC did with Gail Dimler Harrison, and they even saw some hearing loss in teens that they think may be due to congenital CV infection in a cohort that they had. And the hearing loss may be stable, it could be progressive, it can be fluctuating, it can be unilateral or bilateral, it can vary degrees. So the bottom line is they don't have a certain way they look. It has a very inconsistent audiometric configuration, and most pediatric audiologists can tell you this, and anyone in the room that has worked with these kids will tell you that they don't fit a pattern like you might see in some other things. So one thing that Mary Elaine had mentioned is that we wanted to see whether some things about, so there's some ideas about should we do some targeted screening. In other words, if universal screening is too hard or too far of a stretch, can we do targeted? In other words, if a baby referred on the newborn hearing test, maybe we should test them for CMV. And we found that about 7% of the positive babies referred compared to just the negatives, which was around 0.9 in our mixed group from our 7 sites. And what we found is that we could identify those that referred. Not surprisingly, we had some false positives, but more concerning is we had false negatives. In other words, we had children who passed their newborn hearing screen, and then when we saw them at 6 weeks of life and had a full diagnostic audiology evaluation, they had some mild hearing loss or moderate hearing loss. So it could have happened between birth and then, because they can progress, or it could be testing limitations or whatever. So these kids, if we're doing targeted screening, they would have just been missed until the parent noticed they couldn't seem to function as well or couldn't hear or something, but they wouldn't have been picked up. So this method works. We published in Pediatrics. About 57% of CMV hearing loss at birth is identified. So this isn't going to be perfect. It's not going to identify everybody, but at least it's a start. So also what's happening right now is there's been studies of antiviral therapy and for symptomatic infection, and it's shown, they did ganciclovir, but now they use the oral valganciclovir, and they were able to show that you could stabilize the hearing loss at least through 24 months of age. So that's good news, because maybe even if it's not long lasting, maybe if we get to those first crucial 3 years, that's better than the hearing. So that's going on. So we were part of a group, Suresh Popanna, myself, and David Kimberlin in Brisbane, Australia a couple of years ago, came up with a consensus recommendation that symptomatic CMV babies that are moderate to severe are the only group right now that are recommended to have treatment. It's the only group that we have data in. And it's 6 months of oral valganciclovir. It should be started within the first month of life. You have to do some monitoring of neutrophils and viral load. Doesn't have to be done, and you treat for 6 months. It's not recommended. It's not routinely recommended for mildly symptomatic CMV. In fact, what we mean by mildly is those that have transient symptoms. However, doctors will still treat. That's why we say not routinely recommended, because that means we don't really have data to document at this point whether it's effective or not. And then we also, this consensus group said not to do asymptomatics with isolated hearing loss alone. However, many pediatricians will treat. Again, that's not based on any data. It's inferring from the symptomatic. So there's studies underway to do that. And then basically not recommended for asymptomatic congenital CV infection at this time, and not for less than 30 years. So moving on. So we know all this stuff about CMV, but what do women who are in the childbearing age know about CMV? Not much, right? So in 2005, 22% had ever heard of CMV. 2010, we didn't get any better. It's about 13%. We'll skip that. And we just did a study this last year or so, and we found that about 14% of pregnant women in our study had ever heard of CMV. And in this study, we were trying to see, first of all, you have to make women aware before you can talk about, is there any prevention? Since there's no vaccine right now, what can we do? Well, there's some small things that they could do to change some of their risks, such as avoiding saliva and urine. So there are parent groups that are very interested in this. So we took 215 women and we randomized them to 2 groups. We had a CMV prevention group. We gave them a little video. We talked to them. We did text messaging for 12 weeks, with just the messages about CMV. and sent them home with a take-home packet. And then we had a control group that got like a stress reduction in pregnancy messaging. And we followed them up. And so our messages were very simple. It was prevent CMV by not sharing toothbrushes, cups, spoons, utensils, wash your hands, and then also avoid kissing your child on the mouth where you come into contact with saliva. Now, I have to say that healthcare professionals are very concerned about this because we're interfering with the bonding of the child. But you'll find that it's interesting, and this was our plan to protect my baby, so we sent them home with some messaging. This is just the taking care of me. They got 3 messages too, just different. But what we found is that at the beginning of the study, both groups, about 40% said they were kissing young children on the mouth. And our prevent group, which is our group we were trying to change behavior, they dropped to 10%. So they heard our message and said, you know what, this isn't hard to do. I'll do this to protect my baby. The same thing with sharing the food, drinks, and everything. They went from 47% to 15%, so they made a change. Hand washing didn't change that much because it's sort of, I always say it's sort of like dental floss. You know, if the dentist asks you to floss your teeth, you say, you know the right answer, right? Yes, I do, right? So same thing, you ask someone if they wash their hands, oh yeah, I do every time. And so we didn't have a way to test that. So anyways, so what's also going on at this time, and the parents are very interested in this, is parent advocacy. So there were a whole bunch of groups that were meeting, and in 2014, in the U.S., they formed the National CMV Foundation. And their goal is to provide some, to inform, to engage, and to advocate. And so it's not just in the United States. Like it's in Spain, it's in England, France, Italy, Canada, Australia. So they're very active because now that we're all connected by social media, it's a good way to communicate. So they have very active blogs and programs. And what's happened is they've been very active in legislation. So what happened in Utah, I'm checking my time, there was a child born who had hearing loss, and they weren't sure. The ENT saw her, and they said, well, I don't know, let's see if we can get her dried blood spot, test her for CMV. She was positive. Her mom, who was a special education educator, said, well, haven't I ever heard of this? I've never heard, what is this? And the grandmothers are awesome, said, I also am a special education professional, and I've never heard of this. But she happened to be a legislator in Utah. So they passed the first legislation in Utah to do the targeted screening, where if a baby referred on the newborn hearing test, they would get CMV tests, as well as they wanted to provide education for daycare workers, for young women of childbearing age, etc. From that, it snowballed. So we now have about 9 states, Oregon, Idaho, Iowa, just this year, have passed some kind of legislation. Some, like in Texas, are just to educate women. That's all they're going to do. Tennessee, the same thing. Connecticut, Illinois, Oregon, Idaho, I think, Utah, are all doing the screening. They're referred. But what's happening is even in the states that's not legislated, there's large hospitals that are saying, we're going to do it anyways. We think it's important to do. And you can see that the blue states, or the cyan states, those are ones that are in process, and then the gray ones mean people are interested in those states. So I added up all of the states together, and we're now at about 25 states that have some interest in it. So this is all nothing to do with me or you. It's all driven by parent advocacy. So I'm impressed with these moms. They worked hard, and the grandmoms. So the future, where are we at? So I think what that people are focusing in on now is doing targeted CMV screening. It's not perfect. It's not going to identify all babies, but maybe as we identify more, people will consider using saliva. Actually, I just talked to an OB at a meeting, and Ontario is getting ready, in Canada, the whole province, they're going to implement universal CMV screening. And I'm like, wow, we're going to need to go to Canada. And then also Maine put their legislation forth this year to is considering it through their legislation to do universal screening. It got tabled, and they're actually, these parents in a lot of these states, the first time they went up, they got tabled. Guess who opposed the parents the most? Who do you think opposed the parents the most when they showed up? The medical professionals. The pediatricians, the others, they were like, oh, no, we don't want you to legislate what we're doing. And the parents said, thank you very much. We're going to do what we want to do. Because that's one thing they told me I'm just going to comment on that because we're talking about parents advocating for universal CMV screening. Parents about, 5, 6 years ago, I don't have all the answers about CMV. I'm a scientist. I love studying about CMV, and I love to talk about it. But I don't have all the answers. So I was kind of hesitant to talk, because when we start to talk to parents, we always want to say, well, it's not likely, but we don't want to say it's 100%, We're always careful because we don't want to give them false hope and all this. And one of those parents looked at me and said, you know what? This is patronizing. Give us the information and let us make up our own minds. And I thought, you know what? They're right. And, and we forget that sometimes. So that has been my involvement with them, and and they participated. They started showing up in our meetings. They started speaking up. I have to say, for non-trained, many of them are trained in other areas. They might be like a marketing specialist or something else, but they've learned a lot about CMV. I'm impressed, and they really are the warriors because they also care for their children who have lots of different issues. So currently the future is more studies of antivirals. Dr. David Kimberlin is starting a clinical trial to look at asymptomatic children with CMV without sensorineural hearing loss and doing valganciclovir. So they're going to screen at 12 sites, then try to enroll children. And so we can see if it works as well for those that don't have hearing loss at birth. Can it prevent hearing loss later? Because that would be incredible. And then there's also another one done by Dr. Albert Park in Utah, where when they identify them with hearing loss and CMV, they're going to be enrolled into another study to look at if valganciclovir makes a difference to prevent this hearing loss to get worse. And then we need further studies because if we're going to screen babies, or even if we do referred testing, we're going to end up with some babies who have CMV but don't end up having hearing loss. And so they're asymptomatic. What do we do with them? Do they need further testing? What else do we need how do we clinically manage them? So those are things we're looking at. And then I mentioned before the non-primary, and we're doing some genomic studies. Colleague Shannon Ross is leading that. And then there's vaccine development. I know Merck is doing some things, and also I think GSK. So I think there's always hope. And then there's also development and implementation of behavioral interventions. While we wait for the vaccine, maybe we need to make more women, more than 14% of women need to hear about this, because you hear about what? Don't change the cat box litter, don't the pasteurized. So why can't we give them a simple message? And that's what the parents say. What's so hard about this? Can you not do this? And then what's the risk reduction? I always say it's harder to explain, don't kiss your baby. It doesn't mean don't kiss your baby or cuddle. It just means try to avoid the saliva, which, personally, we all would probably prefer that anyways, but it's just impossible. But can you do it for a while you're pregnant so you don't get a reinfection or a first infection? And it's simple to do. And then the parent advocacy for the future is they're running CMV awareness campaigns. They're promoting universal CMV screening. They're drafting legislation. They're developing messaging. I want to have a video contest, a simple message. I saw Melanoma did it. And they had some fantastic things on YouTube you could vote for, and they were clear. So we're going to try to open that up because there's got to be some clever computer person out there who can message a simple message for CMV. Because when you start talking about, well, if you're negative, So, how can we do that? So those are some of the things that are going on both scientifically and then on the more public health and advocacy way. And the final thing that I want to show, and we may have to adjust the sound, is just a short video of some parents talking about their daughter's experience with CMV. And she's just a cute little girl, but she's very typical of a child with CMV who had some problems at birth, who then now has hearing loss, has a cochlear implant and a hearing aid. And it's sort of their story and what they wish they had heard about CMV.
Okay, ready?
Yep. Tell me about yourself. Tell me about you.
I'm Caitlin Hill, and I love to play.
Caitlin is my second child, and my first pregnancy was so easy.
A couple of ultrasounds before Caitlin was born, there were things happening medically, with the ultrasounds that made us nervous.
And I just assumed when they said, well, we've got this problem, but this one cleared up, that it really wasn't that big of a deal.
I always felt a little bit left down in that way, that we didn't have a whole lot of information. Nobody said, hey, this is actually a big deal. Your baby could be in danger. I don't know if they wanted to protect our feelings or what, but it seems like it was underplayed a little bit.
She was quiet when she was first born. They did a C-section and they had her, and we kept waiting for that cry. And we did hear it, but it was little.
She was 4 pounds 10 ounces, so she was very small. She had all these health issues.
It's really common. It's the most common congenital virus.
When I know somebody's pregnant, I always say, hey, do you know about CMV? And they almost always say no.
I would like it to be just another thing that women know about, something that women know to avoid. So I'm educated, I know about CMV, and I still got told, oh, it's not ever going to happen again. It's so rare. Your case was kind of isolated, and it's not rare. It's pretty common, and they're just not getting the education that they deserve. I didn't think that, 7 years down the road, we would still be in speech therapy and going to doctor's appointments and dealing with effects of this one virus that caused so much damage.
I was born being really sick. And then somehow I was getting deaf. So when I was at least 4, I got my hearing aid.
So now she is 7, and she is completely deaf in her right ear, and she's got a moderate loss in her left ear. And so she uses a cochlear implant on the right side and a hearing aid on the left side.
I'm pretty happy that Jesus made me up with my mom because I don't get in trouble a lot.
She doesn't see those kind of dividing lines that we see. Everybody's her friend. It doesn't matter who they are, how they look, how old they are. They're all her friend, and she's so open, and she's so happy, and she'll give anybody a hug. And when she grows up, she wants to bake cookies and give them to people. And that's just Caitlin. She just is loving.
Nobody knew what it was, but I wish we'd been given a little bit more information.
It's not hard. It does take a little bit of a shift and some intentional behavior, but you do that all the time when you're pregnant anyways. And you're accustomed to that. You understand the importance. And I think that moms are willing to do anything to protect their kids as long as they know about it.
I love how I am. I'm a perfect girl. I have a perfect home, perfect mom and dad, and most of all, perfect sisters and brothers. I am the perfect girl in my family. I'm a little too perfect from the others because they are not this. So, too bad for them.
So that's it. But I thought that really covers what we see with kids with congenital CV infection and how they can become, they're such delightful children. And I appreciate the Hill family sharing their stories. Thank you.